Here's a question I want you to sit with for a moment. If your testosterone is low or trending in the wrong direction, the instinct most athletes have is to ask how to increase it. And that's understandable, of course, but it's actually the second question you should be asking. The first question is, what's suppressing it? Because in athletes, and especially in masters athletes over age 40, low testosterone is very rarely a primary hormonal failure. It's almost always a downstream consequence of something else that's happening in the physiological system upstream. And if you don't identify what that is, you're treating a symptom while the actual driver just keeps on running. Hi, I'm Dr. Jason Barker. I'm a naturopathic doctor, I'm a 2-time Ironman finisher, and I've spent 20 plus years working with endurance athletes. So today we're getting into the specific mechanism of how training stress suppresses hormones and why it hits harder after age 40 than it would have a decade ago, and what that tells us about how to actually fix this. So let's start with how the stress-hormone relationship actually works, because this is the physiology most athletes have never had explained to them. Your body has a fundamental hierarchy of priorities. Survival comes first. Everything else, including building muscle, adapting to training, and producing anabolic hormones like testosterone, comes after. When your body detects high physiological stress, it shifts resources towards immediate energy production and away from long-term functions. Recovery, tissue repair, reproductive hormone production, performance adaptation, all of these get downregulated when the stress signal is high enough or sustained for long enough. This is orchestrated primarily through the HPA axis, the hypothalamic pituitary adrenal axis, which governs your cortisol response. And cortisol is the key variable to understand here because it sits at the center of the suppression mechanism. Here's the specific pathway. When the hypothalamus detects sustained stress, it signals the pituitary gland through corticotropin-releasing hormone. The pituitary responds by releasing adrenocorticotropic hormone, or ACTH, which drives cortisol production from the adrenal glands. So far, that's appropriate stress physiology. But here's where that cascade becomes a problem for testosterone. The pituitary is also responsible for releasing LH, or luteinizing hormone, which is the primary signal that drives testosterone production in both men and women. When cortisol is chronically elevated, it suppresses gonadotropin-releasing hormone from the hypothalamus, which reduces LH output from the pituitary, which directly reduces testosterone production downstream. This is sometimes called functional hypogonadism. The testes or ovaries are capable of producing testosterone, but the upstream hormonal signal telling them to do so has been suppressed by the stress response. And there's a second mechanism running simultaneously. Cortisol and testosterone compete for shared precursor hormones in the adrenal pathway. So elevated cortisol doesn't just reduce the signal for testosterone production, it literally competes for the same raw materials to some extent. That's two distinct suppression mechanisms operating at once, and both of them become more significant after age 40 because your baseline testosterone production is already declining, so you have less buffer to absorb that suppression before it becomes functionally significant. Now let's walk through the specific drivers in masters athletes because they're different in important ways from what you'd see in a 20-something-year-old athlete. The first driver is chronic cortisol elevation from training load. So short-term cortisol increases from hard sessions are normal and appropriate. It's acute stress physiology working correctly. The problem is when training load is high enough and recovery is insufficient enough that cortisol stays elevated rather than returning to baseline between those exercise sessions. For masters athletes specifically, this threshold is lower than it was a decade or two ago. The same weekly training volume that your HPA axis could absorb at age 30 may now be enough to chronically suppress the gonadotropin-releasing hormone, luteinizing hormone, testosterone axis. That's not hypothetical. It's a predictable consequence of the physiological changes that come with age. You're not less capable of training hard, you're less capable of absorbing the cortisol consequences of training hard without adequate recovery. That's a meaningful and underappreciated distinction. The second driver is low energy availability, and this is one of the most common findings I see in masters athletes specifically for the reasons we covered in the last video. When caloric intake doesn't meet training demand, the hypothalamus detects an energy deficit and downregulates reproductive hormone production as a direct consequence. This is the red S mechanism, relative energy deficiency in sport, and it operates independently of training stress. So an athlete who is both under-fueling and under-recovering is getting hit by two separate suppression mechanisms simultaneously. The third driver is sleep disruption, which affects testosterone production through yet another distinct mechanism. The majority of luteinizing hormone pulsatility, the hormonal signal that drives testosterone production, occurs during sleep, specifically during deep, slow-wave sleep cycles. When sleep is shortened or fragmented, that LH signal is disrupted, and testosterone production drops as a direct consequence of this. And as we covered, sleep architecture changes with age, making this harder to protect at exactly the stage of life when it really matters the most. Now, the fourth driver is what I'd call the chronic overtraining hormonal cascade, and this is where things get particularly important for masters athletes to understand. When training stress consistently exceeds recovery capacity over weeks and months, the HPA axis goes through a predictable progression. In the early phase, cortisol is chronically elevated. The system is working overtime, trying to manage a load that it just can't keep up with for too long. At this stage, the suppression of testosterone through gonadotropin-releasing hormone pathway is significant and ongoing. But in more advanced or prolonged cases, the HPA axis essentially exhausts its output capacity. Cortisol becomes flattened and blunted. The system can no longer generate appropriate cortisol even when it should. This is what we used to refer to as adrenal fatigue, more properly known as HPA axis dysfunction. And at this point, DHEA, dehydroepiandrosterone, typically drops significantly as well. DHEA is worth understanding on its own because it's not just a testosterone precursor, it's an anabolic hormone in its own right with important roles in tissue repair, immune regulation, and energy production. And unlike testosterone, which gets a lot of clinical attention, DHEA is frequently overlooked in hormonal panels. For masters athletes, this is a meaningful gap because DHEA naturally declines with age even more rapidly and consistently than testosterone does, making it a particularly relevant marker in the masters athlete population. There's also a thyroid piece worth mentioning here. Chronic high cortisol impairs the conversion of T4 to the active T3 form of thyroid hormone in the peripheral tissues. So an overtrained masters athlete can have normal thyroid hormone production and still have insufficient active T3, which affects metabolic rate, energy, body temperature, recovery, and performance. This is another way overtraining creates downstream hormonal disruption beyond just testosterone. And finally, SHBG, sex hormone binding globulin, can increase under conditions of chronic stress and low energy availability, which binds more testosterone and reduces the free fraction that's actually bioavailable to the tissues. So even a total testosterone number that looks acceptable can mask a significant reduction in functional testosterone availability. This is why testing free testosterone alongside total testosterone matters so much. Now, how does this present differently in men and women after age 40? Because there are some important distinctions we need to make here. So in men over 40, this cascade typically compounds natural andropause. Baseline testosterone is already declining, SHBG is often rising with age, which further reduces testosterone, and the chronically elevated cortisol to testosterone ratio from overtraining tips an already challenged system further out of balance. The clinical picture is declining performance, loss of strength, poor recovery, reduced libido, mood changes, and fatigue that just doesn't respond to rest. In women over 40, the picture is more complex because it's happening alongside the perimenopausal hormonal transition. Estrogen and progesterone are shifting dramatically, and testosterone, which was already low to begin with, is often declining simultaneously. The overtraining-driven cortisol suppression of GnRH, gonadotropin-releasing hormone, affects both the sex hormone pathways and the adrenal testosterone production that becomes increasingly important as ovarian production declines. Female masters athletes in perimenopause are particularly vulnerable to this cascade, and it's dramatically underdiagnosed because the symptoms get attributed entirely to menopause or perimenopause, rather than to the specific and addressable contribution of overtraining-driven hormonal suppression layered on top of it all. So what do you actually do about all of this? The intervention has to address the specific drivers rather than just the numbers. And for masters athletes, that means being more deliberate about this than a younger athlete would need to be. You want to reduce the total stress load, training volume, intensity, frequency, enough to create space for the HPA axis to recalibrate. This is often a more aggressive reduction than athletes want to accept, but the HPA axis doesn't respond to partial measures the way it might have at a younger age. Correcting energy availability immediately and consistently, getting adequate carbohydrates, total calories that genuinely match training demand, and protein in the range of 1.6 to 2.2 grams per kilogram, or 0.7 to 1 gram of protein per pound. The hormonal consequences of underfueling don't wait. They're operating in the background the entire time intake is insufficient. You need to protect sleep deliberately rather than hoping it happens. Deep sleep is when testosterone is produced and when the HPA axis recalibrates its output. Protecting sleep quality and duration is a direct hormonal intervention, not just a wellness recommendation. Support the specific systems that are dysregulated: magnesium for nervous system regulation and sleep quality, omega-3 fatty acids for inflammation management, and adaptogens. Ashwagandha at 300 to 600 milligrams of a standardized extract specifically addresses HPA axis dysregulation with consistent evidence for cortisol reduction and downstream improvements in testosterone as well. Rhodiola at 400 to 600 milligrams in the morning addresses stress resilience and mitochondrial function under physiological stress. And then you need lab testing because the pattern matters as much as any individual number. Here's the testing picture for the specific situation. You want to get a multi-point salivary cortisol test to assess the full daily rhythm, not just whether cortisol is high or low, but what the pattern actually looks like. Total testosterone, free testosterone, and sex hormone binding globulin together, because free testosterone is often where the real suppression is actually visible. DHEA-S, which is frequently overlooked and often significantly depressed in overtrained masters athletes. A thyroid panel, including free T3, because peripheral T4 to T3 conversion is often impaired under chronic training stress. And upstream markers, a total iron panel, and ferritin, because iron deficiency is extremely common in endurance athletes and directly affects energy production. Also markers of gut barrier integrity, because as we covered in earlier videos, increased intestinal permeability drives systemic inflammation that compounds every other aspect of this picture. When you look at these together, you stop seeing isolated numbers and start seeing the pattern, which is what actually tells you where the intervention needs to happen. So to put it all together for masters athletes specifically, when testosterone is low after age 40 or so, the first question is always what's suppressing it, not just how to raise it. The suppression mechanism runs from chronic training stress through HPA axis dysregulation, through gonadotropin releasing hormone suppression, to reduce luteinizing hormone output, to lower testosterone production, a cascade that's predictable, measurable, and largely addressable. But it's running on top of a natural decline that means your buffer for tolerating that suppression is smaller than it was a decade ago. Fix the drivers: energy availability, training recovery ratio, sleep quality, stress load. Support the systems that are dysregulated. And then use lab testing to identify the specific pattern rather than just guessing at which part of the cascade is most broken. That's how you separate what's addressable from what's genuinely aging, and that distinction is everything for a masters athlete who still has some serious training ahead of them. In the next video, we're getting into hormone lab testing specifically for masters athletes. What should you run, and how should you interpret it through an athletic rather than a disease screening lens, and what the results are actually telling you. Please hit like and subscribe. I post science-backed content for athletes navigating performance at every stage of life. And for individualized hormone testing and protocols built specifically for masters athletes, visit naturalathleteclinic.com. I'm Dr. Jason Barker. Thanks so much for watching, and I'll see you all in the next one.